If not, thank Dr. Bratis, and we can continue to the next speaker. And the pointer is over there. So the next speaker is Dr. Prijic, who will discuss neonatal aortic stenosis, balloon valvoplasty versus a surgical repair.
Thank you very much, distinguished professors and scientific committee members and dear friends, dear colleagues. It's a great pleasure for having opportunity to have this lecture today in front of us, in front of you. Actually, in the beginning, there was intention for having two lectures about neonatal aortic stenosis from surgical and from interventional point of view. But after surgeon canceled his lectures, I was asked to join that two lectures in one, and because of that, predicted time is actually 40 minutes. But don't be worried, I will try to make it to be shorter. Actually, the lecture will have three parts. First part is difference, to make a difference between single and biventricular repair. Second part is to make distinguish critical and non-critical aortic stenosis. And third part, which is most important, to see advantages of balloon and surgical valvulotomy. Single or biventricular repair. We have to go back in the fetal period to understand aortic stenosis well. Actually, most important period of cardiomyocyte proliferation is fetal period and first year of life. If we can see on this slide that actually all of us actually here, I hope that no one had infarction, all of us have 4 billions of cardiomyocytes. 1 million proliferate during the fetal period, and second 1 million during the first year of life, and until 20, the cardiomyocyte proliferation stopped. During the fetal period, heart demand actually good environment for having normal proliferation. What does mean a good environment? That means that heart needs optimal blood flow from the left ventricle to the aorta, and optimal afterload, optimal pressure during the second, especially during the second and third trimester of the pregnancy. If we don't have it, if we have a patient with aortic stenosis, we will have situations with decreased amount of the blood flow, which will cause underdevelopment of the heart chambers, and we will have increased afterload and pressure with hyperplasia during the fetal and hypertrophy after the birth. We saw a lot of things about fetal interventions, but I will say that we have to know is the patients with fetal stenosis patients with potential for HLHS, and in the case that we can consider HLS potential, we will have patients with left ventricular hypoplasia, but Dr. Marek told that a lot of patients had also dilation, not just hypoplasia, but dilation of the left ventricle. Then left ventricle is dysfunctional, more and less with hydrops fetalis, and after that aortic arch is with retrograde flow. We will have endocardial fibroelastosis, left-right shunt on PFO level, and mitral valve inflow is monophasic, and the pulmonary veins have bidirectional flow. But what is the most important on the right side? You can see a pie. Actually, if we have all these parameters, we will have 1/4 of the patients who will be candidate for biventricular repair. Okay, 1/4. 3/4 of them will have IGL-HS. Because of that, sometimes one can consider fetal balloon valvuloplasty. 4 out of 5 criteria should be should be present. First of all, a long axis left ventricular size should be more than z-score minus 2. Then left ventricular short axis also bigger than 0. And the normal size of the mitral valve bigger than z-score minus 2, and aortic valve bigger than z-score minus 3.5. And normal pressure in the left ventricle, which means more than 20, but we saw that it's actually more than 30 on the previous lecture. But on the right side of that slide, we can see that if we perform fetal balloon valvuloplasty, we will have only 1/4 of patients who will have possibility to have biventricular repair. If in that patients we can then consider biventricular function, but only 4. But we have to remember that we have a lot of patients who will have complications. We have more than 10% of patients who will actually have very important complications, including the death. That means that we can expect only 1/4 of patients who have fetal balloon valvuloplasty to transpose from the univentricular to biventricular repair. Only 1/4 of them, but we have to consider also a lot of patients who will have complications. In patients with biventricular repair, balloon valvuloplasty, surgical valvulotomy, Ross operation, and sometimes in up to 1/4 of the patients, no surgery and balloon intervention will be needed. Actually, fetal circulation in placenta is actually natural ECMO, and there is no problem during the pregnancy. Problems appears when patient is birthed. And then we have to consider, is that patient for univentricular or biventricular repair? And most important issue for biventricular repair is actually optimal size of the left ventricle and function to support the systemic circulation. And it's actually defined by appropriate stroke volume, which means systolic function, and appropriate left atrial pressure, which means diastolic function. It remains controversial as to when a left ventricle is too small, such that the biventricular repair is abandoned in favor of the Norwood procedure and protocol. Actually, that the patients are patients with borderline left ventricle, with hypoplasia of aorta and aortic root, with endocardial fibrinolysis, mitral valve abnormalities, and associated left-sided lesions, like coarctation is. And then we have patients in front of us, and we have to decide what to do, univentricular or biventricular repair. In our institutional practice, actually, we use two kinds of scores. So one is Rhodes score, and the second one is Collins score. Most important parameters and requirements for biventricular repair are related to left ventricular size. Left ventricle should be bigger than 20 milliliters per square meter. It was calculated by approximate median heart rate, which is 120, and median ejection fraction, which is 75. That means that you need a diastolic diameter of 20 milliliters per square meter for having cardiac index, which is bigger than 2 liters per square meter. Also, very important parameter is long axis ratio. It's actually a ratio between the long axis of the left ventricle from the point of the AV valves to the apical part of the chamber, and the ratio between left and right ventricle, and it should be more than 0.7. If it is less than 0.7, that patient doesn't have a chance for a biventricular repair. And it's actually very easy to decide, is that ratio bigger than 0.7? If the apical part of the heart belongs to the left ventricle, then ratio is for sure bigger than 0.7, and it's approximately 1. If patients have endocardial fibrinolysis, which is 1 or less than 1, aortic valve and aortic root with z-score, which is bigger than -2, same as with mitral valve. And we can see if the Rhodes score is less than -0.35, and Collins score is less than -0.65, mortality rate after biventricular repair is more than 90%. Second part of the lecture is distinguish the critical and not critical, non-critical aortic stenosis. Very important is actually nomenclature. We have to decide which kind of aortic stenosis we have, and we can say that we have 4 possibilities. The first possibility on the left side of this slide is HL/HS, actually patients with univentricular heart. But if we have a biventricular heart, we have 3 additional options. First of them is critical aortic stenosis, which means we have patients who is duct dependent. We have duct dependent systemic circulation, borderline left ventricle, heart failure, acidosis, and pulmonary hypertension. That's a critical aortic stenosis. Second manifestation in the class is so-called severe aortic stenosis with heart failure. One can say that this is also critical aortic stenosis, and some authors call this manifestation of aortic stenosis as critical, but it is actually severe with heart failure, which means we have depressed left ventricular function with decreased fractional shortening, but left ventricle is adequate in size, and patient doesn't have acidosis, but does have a heart failure. And the third possibility for biventricular heart is non-critical, which can be severe, moderate, and mild. In first case, if you have critical aortic stenosis, hybrid procedures are recommended. In second case, if we have decreased ejection fraction, heart failure, mostly balloon aortic valvuloplasty should be done. And in third case, if we have non-critical, we can have a debate: is balloon or surgery should be performed. If we have first case with the critical aortic stenosis and with actually severe with heart failure, aortic stenosis, we can, Dr. Marek told about that, we can consider hybrid procedure. What that means? That means that we have actually bridge to biventricular repair, and we give a patient time to recover, and the patients can declare himself or herself as 1 or 2 ventricular candidate. If we have duct-dependent critical aortic stenosis with circular instability, in that case, which kind of operations should be done? First of all, surgical aortic valvuloplasty, then Blalock-Henlon, actually atrial septostomy, along with the bilateral pulmonary band, along with PDA leave open with stent or with the prostaglandins. Second option is circular instability with severe left ventricular dysfunction. Then we perform balloon aortic valvuloplasty along with the balloon atrial septostomy and PDA leave open. And the third case is with circular stability, left ventricular dysfunction, then balloon aortic valvuloplasty and leave PDA open is enough. It is actually studied from Sweden on 107 neonates, and actually they considered that patients with critical and severe aortic stenosis with heart failure, actually on the left side of the spectrum, have worse prognosis. Actually, we can see that their freedom from intervention, freedom from aortic valve replacement, and even free survival is worse than in patients with non-critical stenosis. It's very important. Why? Because balloon aortic valvuloplasty is recommended and preferred in that kind of patients. We will see later why that is important. Actually, risk factors for these patients are smaller AV valve with a higher post-interventional gradient, and for intervention and for aortic valve replacement, it's actually smaller AV valve and new onset aortic regurg. They show that valve leaflet, it is very questionable about valve leaflets. They show that valve leaflet morphology was not associated with significant risk of intervention or for aortic valve replacement. In one sentence, critical aortic stenosis has worse prognosis than non-critical. And third part is what to perform, balloon or surgery. Actually, indications are for immediate intervention is newborn with the critical aortic stenosis duct dependent, and the newborn with or infants with the left ventricular dysfunction due to severe aortic stenosis regardless of gradient pressure. And elective interventions is performed if we have non-critical patients with Doppler gradient of more than 64, mean more than 40, and peak-to-peak gradient on intervention more than 50 millimeters of mercury scale. Procedure, balloon is performed after appropriate echo analysis. On general anesthesia, puncture is according to the echo guidance and with the surgical, sometimes with the surgical cut down. Access is usually retrograde, sometimes is antegrade. Heparin should be administered, and autography is performed through the pigtail 4 French catheter in different projections. And we have to see about valve opening and aortic regard visualization. And also we measure annulus of aorta, and we also see about echo measurements, and we compare them and we decide about appropriate size of the balloon. It's very important to cross the valve centrally with a wire which is 0.14 or 0.18 or bigger. With soft catheters, after that if we are inside of the left ventricle, we perform hemodynamics with the left ventricular angio, and we decide about balloon, which also should be a short and soft, like Taishak Mini with 2 centimeters in length is used. And balloon to annulus ratio should be in between 0.9 and 1. And even smaller if valve is dysplastic. We performed 2 or more inflations, and it's very, it's questionable should pacing be performed along with balloon dilation. I spoke with Professor Parezanovic about their experience, and sometimes we use it, sometimes we don't use it. There are arguments for and contra. And also hemodynamics and angio after intervention is performed. About surgery, actually commissurotomy, open commissurotomy is performed. After that, shaving of the cusp, and on the third part of this slide we can see the result. Other technique is closed valvulotomy, and sometimes Ross plus minus cono is bailout option. I will show you now shortly to our patients. The first one is a 10 days girl with severe aortic stenosis, with preserved systolic function, no heart failure, with actually systolic murmur. All these patients have weak femoral and brachial pulses. All pulses are weak. This patient doesn't have heart failure, has a small aortic valve, 7 millimeters in diameter. Gradient pressure was 83, and the patient had post-stenotic dilation with left ventricular end diastolic diameter, which was minus 3.3, with left ventricular hypertrophy and preserved systolic function. But a few days after, when we performed intervention, actually patient was in heart failure. She had a depressed systolic function, and the gradient pressure was only 30 millimeters mercury scale, as you can see. We had patients with a very thin flow from the left ventricle to aorta, and dysplastic aortic valve with inappropriate excursions. When we push the roadrunner wire inside of the left ventricle, we have very unpleasant event. The patient had ventricular tachycardia and ventricular fibrillation, and we fortunately resuscitated her with the direct current defibrillation, and after that we had a sinus rhythm. And after that, balloon dilation with Taishak Mini balloon 6/2 was performed on 3 occasions. We performed it with rapid pacing rhythm of 230 millimeters mercury scale, and had appropriate result. Actually, we have the flow which was thin on the left side and very wide on the right side, and echo gradient pressure was 83, and after intervention 45 millimeters of mercury scale with normalization of the pulses. After 5 years, patient is clinically completely well, with normal pulses, normal EKG, normal echo, and the aortic valve gradient is actually very good, 36 millimeters of mercury scale, and patient has only mild aortic regurg. Actually, optimal finding after 5 years after balloon. I have to say that our institutional experience with aortic stenosis is pro balloons and contra surgery. One patient from surgery, actually patient's 15 days, girl with severe aortic stenosis with depressed systolic function, heart failure and pulmonary hypertension, systolic murmur, weak pulses, tachypnea, delayed capillary refill, somnolence and acidosis, and treatment for acute failure was administered. Patient had small aortic valve, 6 millimeters in diameter, gradient pressure of 50 millimeters of mercury scale, small end-diastolic diameter of the left ventricle, -2 Z-score, depressed left ventricular systolic function, fibrinostosis, moderate hypertension, and PDA with bidirectional shunt. We tried balloon, but we failed. And after that, commissurotomy, surgical commissurotomy was performed. And actually, result was actually very good, acceptable, with 35 millimeters of mercury scale stenosis and moderate aortic regurg. But after 2 years, patient had severe aortic regurg, and Ozaki procedure, aortic valve replacement, was performed in the United States. When I was younger, and my actually PhD thesis was a non-critical balloon and surgery for aortic valve stenosis. We had a visit from Professor Grażyna Brzezinska, and I asked her what is the better option. She told me, whatever you choose, it's always just a first touch. And it's actually is the truth. All the patients with aortic stenosis require lifelong follow-up, irrespective of the type of intervention. And this is our actually study. We show that results are very comparable, but it is a study in patients who are more than 1 month. In patients who are non-critical aortic stenosis, balloon is less invasive, but surgery provide a slightly better results. Also, very recent study that we presented on an annual meeting of a Japanese Society of Interventional Cardiology 1 month ago. Actually, we showed that after balloon, we can expect it that patients will not have intervention in a 13 years period, and after surgery in 18 years period. And related to aortic valve replacement, that period is 16 years and 20 years. And we can conclude that balloon is preferred treatment in patients with aortic stenosis who are older than 1 month. But is it same in neonates? If you ask a surgeon, they will tell us it depends on the valve morphology. Actually, if you have tricuspid, if you have asymmetric bicuspid, if you have unicuspid valve, you can go to surgery. If you have symmetrical bicuspid valve, then you can perform balloon. Generally, if you have decreased, depressed function of the left ventricle, then you go to balloons. And if you have additional defects, you can go to the surgery. Actually, this is the biggest, longest term and largest single center study to date that Professor Marek and his team performed in GOS. Actually, 40 years retrospective review. They show that we can expect survival in 70% of patients after 10 years of after interventions, and reintervention rate is a little bit less than 50% after 10 years. Also, they showed that we can conclude that patients will have some amount of the left ventricular myocardial impairment. First of all, left ventricular remodeling with decreased longitudinal and increased radial strain, and with severe diastolic dysfunction, which is due to endocardial fibrinostosis in 20% of patients. Also, that patients had impaired peak oxygen uptake. One big study from Toronto, actually in 66 newborns, just balloons, they showed that freedom from reintervention is 56% in 10 years period, and freedom from aortic valve replacement 79% in 10 years period. If we see which part and parameters are important for worse result, we can conclude same thing. Critical aortic stenosis and severe aortic stenosis with heart failure had worse results. Also, study from Prague with 134 patients, actually they show that patients in newborn period had worse prognosis than patients who are older. But if they exclude patients with critical stenosis and patients with heart failure, prognosis in newborns and older PH patients is the same. Very important study. And also same numbers, intervention rate which increased from 45 to 60% over 10 years period if we exclude critically ill patients. Also, they try to find is there any difference regarding the era, and in the recent years, survival is much better. Also, they showed a very interesting fact that if you choose bigger balloon, you can expect worse result. Interesting for interventional cardiologists. But what about surgery? Surgery, different operation, but in case of Australian patients, more or less same results. 52% of reintervention freedom in 10 years period, and the freedom from aortic valve replacement, 68%. Also, they show that tricuspid aortic valve is associated with suboptimal outcome. Very interesting. It actually, very important, they didn't have mortality bigger than 1%. If we take all that studies in one slide, we can conclude that what can we expect after balloon or surgery? We can expect that we will have freedom from intervention in 50% of patients and freedom of aortic valve replacement in 3/4 of patients after 10 years. Also, we can expect survival rate which is in between 70 and 99%. And we have a few studies that compared results from the balloon and the surgery, and one of the biggest is from Canada and USA, and actually they showed immediate before hospital discharge death, which was 80% in surgical and 11% in balloon group, and also reintervention for aortic valve during the hospitalization was also 30% and 20%, which is actually according to that numbers that I mentioned before. But what about death during the long-term follow-up? Most important is how big aorta is and how big LVOT is, and what was the condition of the patients before the surgery and before the balloon. And no difference between that two kind of interventions. And about reintervention, it's important contractility of the left ventricle, body weight, and level of aortic regurg after intervention. And no difference, but balloon is a little bit poorer result, has a little bit poorer results. Study from the France showed that balloon has lower freedom from an intervention after 10 years with statistically significance. And most important risk factor were associated left ventricular outflow tract lesions and higher gradient pressure and smaller aortic valve. Also, mortality was 20% in balloon group and 31% after 10 years, and in surgical group 8 and 21%. And study for Germany was also pro-surgery as better option for aortic valve in neonate. Why? Because in surgical group, it is in the middle part of this slide. In surgical group, there is reduced need for operation, but survival is same and need for aortic valve replacement is same. And they showed actually that indications for reintervention is mostly regarding the restenosis. It is almost 60%, and only 1/4 of the patients had aortic regurg, important, which demand aortic valve replacement. And if we know previous slide that we can expect half to half reintervention and 3/4 to 1/4 in aortic valve replacement, what now we have? If we conclude, according to that previous 3 studies, we have fact that the balloon aortic valvulotomy is connected with 10 to 15% more reinterventions related to the surgical group. But we have to know that balloon is preferred options in severe aortic stenosis. Thus, it is important for choosing which kind of intervention should be performed. It's maybe a thing that we can debate. We can have a debate about that. And survival rate, I told it's 70 up to 99%. And conclusion, actually beauty is in the eye of the beholder. Balloon and surgery represent primary treatment options in lifelong aortic stenosis management, but that interventions are just first touch. Patients with critical aortic stenosis and severe aortic stenosis with heart failure have a worse prognosis compared to the non-critical patients. Worse prognosis is related to underweight, to undersized LVOT and aorta, and with bigger amount of the aortic regurg and bigger gradient pressure after interventions. And it's also very questionable, but prognosis is not clearly related to the valve morphology. Both balloon and surgery have respectable results with expected 10 years freedom from intervention in 1/3 to 1/2 of patients and freedom from aortic valve replacement in 3/4 of patients, and survival rate which is bigger than 70%. Advantages of balloon is that procedure is less invasive, and advantages of surgery is that intervention is related to better reintervention-free rate. But finally, decision is based on the institutional expertise. And the final slide, actually, I was asking third person, in this case, artificial intelligence, and it was told that interventional cardiologists and cardiac surgeons often face turf wars over treating cardiovascular disease stemming from the 30-year rivalry between the catheter-based procedures and open heart surgery. However, both balloon and surgery have respectable results in newborns with aortic stenosis. Thank you very much.
Thank you for an excellent review on this very difficult topic. Unfortunately, we will not have any time now for questions because we need to move for our lunch break. Okay, but during the lunch break, feel free to ask any questions. Thank you so much.